Okay, we might get started. As I said, good evening or good morning, and welcome to our second webinar for 2023 in the GTC series. It's a delight to have you all here today. I'm Amy Freeman Sanderson, and I'm a speech pathologist based in Sydney and leading the education committee at the moment. So I'm moderating with my co-host, Associate Professor Michael Brenner, the president of the GTC. So our topic today is MDT tracheostomy management for people with persistent and chronic illnesses. I'd like to, at this time, take the opportunity to thank our sponsors, so Medtronic, ATOS and ICU Medical, for their unrestricted educational grants, supporting our mission and vision at the Global Tracheostomy Collaborative of creating multidisciplinary teams of physicians, nurses, respiratory therapists, physiotherapists, speech therapists, and patients and family working together to disseminate best practices and improve outcomes around tracheostomy care. I'd also like to acknowledge the traditional custodians of the lands in which we meet today. And I know there are many lands and diverse lands, so feel free to sort of write where you're joining from in the chat. Today we'll be covering a couple of objectives, and these are the key ones. So outlining the goals of tracheostomy care in persistent and chronic illness, understanding how to optimize health and well-being, recognizing the importance of safety and monitoring in regards to our care, learning about acute respiratory and rehabilitation care goals, and understanding the different MDT roles that different professionals may play in tracheostomy management. We're delighted to have an expert panel of 3 speakers join us today from different parts of the globe. So Dr. Laura Istanbulian, Professor Elaine Prezant, and Dr. George Toumanopoulos from Sydney. In terms of questions, we'll take them at the end. We've got time for a Q&A panel. And just in your Zoom, I guess your options, there's a Q&A button. So please feel free to type in your question there. And we will endeavour to get to as many questions as possible in the chat. In terms of disclosures, just acknowledging the speaker's disclosures here. And with that, I'll hand over to Michael to introduce our first speaker.
Terrific. Thank you very much, Amy. So it's my pleasure to introduce Dr. Laura Istanbulian. She is a nurse practitioner who works with patients who are experiencing persistent and chronic critical illness. Her title is Nurse Practitioner Director of Prolonged and Long-Term Ventilation at Michael Garron Hospital in Toronto, Canada. She supports a patient and family-focused and multi-professional co-led clinician and research program. As to her background, Dr. Istanbulian graduated from Lawrence S. Bloomberg Faculty of Nursing Nurse Practitioner Program at University of Toronto in 2012 and completed her PhD in nursing in 2022. Her doctoral research focused on evaluating a co-designed communication intervention to support adult communication in the intensive care unit. So I'd also like to congratulate Laura on her acceptance to a prestigious faculty position at the Daphne Cockwell School of Nursing at Toronto Metropolitan University, which will be starting in July. We look forward to your talk, Laura.
Thanks, Michael. I appreciate that. Lovely welcome. So good morning, evening, afternoon, night to everyone, wherever you are. I'm very excited to be here with you all, and thank you for the opportunity to share some of the research I've been involved with. The title of my portion of today's talk is Actionable Processes of Care for Patients with Persistent Critical Illness. And as Michael mentioned, I'm a nurse practitioner by profession. And in a few slides, I'll tell you a little bit more about where I work and my patient population and the great teams I work with. So before I begin, I'd like to acknowledge an amazing team of mentors and colleagues who have made this work that I'm going to be talking about today possible. Dr. Louise Rose, who led this research, Dr. Ian Fraser, who is the medical director of our program at MGH, Michael Garron Hospital, Dr. Marcus Cargill, who is our director of respirology and the medical lead of our tracheostomy team, and our multi-professional team. Too many to mention there, but in particular, the extraordinary speech-language pathologist, who I wish one day to be an honorary member of that profession. And of course, our patient and family partners, which we have many wonderful partners. So as I mentioned in the title, my portion of the talk is about actionable processes of care. And again, for patients with persistent and critical illness, persistent and chronic critical illness. And perhaps the term persistent critical illness is familiar to many of you, but if not, it can be thought of as a possible stop along the continuum of critical illness in between acute critical illness, where the focus is resuscitation, and chronic critical illness, where maybe the focus is more primary care. Now, there are much more specific ways that you could potentially define persistent critical illness. So clinically, we can say that a patient with persistent critical illness, or PCI, is a physiologically stable person who's failed repeated weaning attempts. Their length of stay in some regions would be defined as like the 21-day mark, or even greater. And sometimes persistent critical illness is considered synonymous with prolonged ICU admission or prolonged ventilation. Dr. Theo Washina and his team investigated the timing of onset and burden of critical illness using a retrospective population-based observational design. And they suggested that persistent critical illness can be thought to begin with the resolution of the index reason for ICU admission, so maybe around day 11. And now that my talk today is not about specifically defining this patient population in terms of timing, but I think it's important for us to think about who we're talking about, who this cohort is, and what their specific risks are and what their specific care needs are. This is not a large population proportionally, but they do comprise a disproportionate fraction of ICU costs related to their lengths of stay. They have a high one-year mortality and readmission rate, and they experience multiple transitions with risks that are associated with that, and not least of all, patients and family experiencing persistent critical illness experience significant risks of anxiety and depression post-discharge, with also a low probability of returning to independent living in the community. So, as I mentioned, my patient population is at a community teaching hospital in East Toronto, Canada. In our community hospital, we have 4 units that care for patients and family members with mechanical ventilation, invasive and non-invasive, as well as with persistent and chronic critical illness. We have our long-term ventilation unit, our weaning program, we have a long stay program, which is a part of our ICU, and we have our intensive care. And so my program is the Provincial Center for Excellence in Prolonged Ventilation and Weaning. I always get it wrong, PWC. So we work very closely with the other units to ensure that patients are moved appropriately across that continuum. So at our hospital, as I mentioned, we have a weekly physician-led and multi-professional tracheostomy team. We have trach care team rounds that we have every Thursday. Before we started this talk today, we were talking about the merits of Zoom, even though sometimes it can be fatiguing, but we do use Zoom technology to connect all of the practitioners across their various units to discuss these patients. We talk about patients not only in the vented areas of the hospital, but also in general medicine floors. So that way, those patients are supported by this team-based approach as well. And now the focus of these discussions at our trach rounds are, of course, trach management. However, for our longer stay patients who have persistent and chronic critical illness, these discussions also include issues that transcend things that might be more appropriate for a short admission. These include things like supporting communication, supporting mobility rehabilitation, diet, enteral diet, or transition to PO diet, as well as things like goals of care discussions, where people are at with their treatment decisions and overall goals of care. And that's just the beginning of the iceberg. These conversations sometimes take on a life of their own. Now, I'm sorry about the picture on the right. It's disturbing to me, but I think it's an important image. I think it's probably not unfamiliar to many people who work with people who have a longer critical illness stay. But some of the short and long-term physical, emotional, cognitive, and I'll say spiritual potential complications of persistent critical illness and chronic critical illness are listed on this slide. And I'm sure you guys are able to perhaps add even more to this list. And you might look at some of these and say, oh, no, I haven't seen a lot of that, which is fair. But it's a list that's compiled of potential short and long-term complications. And many of these short and long-term complications have their own repercussions for patients and family members, as well as for the overall healthcare system. And so sorry if you guys hear a ding, I have a monitor on. I can't silence it, so hopefully it doesn't ding too much, but I apologize for that. In 2018, our research team, who I mentioned before, was led by Dr. Louise Rose. We reflected on this issue that ICU patients who have persistent critical illness and their families have these complex care needs that are often incompletely met because of the competing needs of acute care patients in the ICU. And we specifically asked the research question, what are patient, family, and healthcare provider reported priorities for care for patients who have persistent critical illness? And our aims, we had 3 major aims for this group of research. Our multi-study project had the aims of first identifying processes of care that are important to patients, families, and clinicians, to develop consensus about what those top processes are that are actually actionable. And then we wanted to think a little more about how to organize care and systems around these processes of care. And so this slide, it's funny how one slide can depict like 6 years of research, but this slide describes the steps that we took to address these aims. These included a systematic review, qualitative interviews with patients and family members who are experiencing PCI or persistent critical illness, and then interviews with ICU clinicians as well. And the interviews with patients and family were done across Canada, but we also had a parallel qualitative study in the UK. And so actually in one of our publications, we were able to compare patient and family reported actionable processes of care between Canada and the UK. The interviews with patients and families were recorded, and we created a touchpoint video and used that video and showed it to the healthcare providers to preempt our interviews with them. After those few steps, we collected all of the reported actionable processes of care, and we conducted a modified Delphi study to prioritize them into what we were hoping to do, the top 10, but painstakingly, we're only able to reduce to 11. When you'll see in the next slide that some of those 11 even had a number of additional priorities or actionable processes care under them. And we clumped them together in appropriate areas, reflecting the nature of the work, but also the profession who would be sort of responsible for it or who would be accountable for leading that work. And that we found that really important to do as we started to think about how we would use this information to change care processes. How would we introduce it to an ICU or care environment caring for people with PCI or CCI? And so I'll just move to the next slide, and I'll just stop here for a second and just sort of reflect on what came out of this. There are 2 sort of pieces of very dense information on this slide. The first one on the left, there is the top 11 actionable processes of care that we deduced using that research process that I described. And the 11 processes of care, I can read them for you quickly here. The first one is involving patients and families in goal setting and decision-making. The second one is providing aids to help patients communicate, including a method to access help at the call bell, promoting physical comfort, minimizing complications, promoting self-care and restoring normalcy, optimizing ventilator weaning, optimizing physical therapy, assessing swallow function and safe return to normal eating and drinking, de-escalation of pharmacotherapy, assessing and treating psychological issues, minimizing delirium risk, and making appropriate referrals. And you can see on the right-hand side of the screen, hopefully not in too small print, and we're more than happy to share this information or the publication with anybody if they'd like to see it, that in some of the 11 categories, there are sub-actionable areas. And again, as I mentioned before, these were considered extremely important to the Delphi consensus. So I'll leave those for you guys to have a look at, but you'll see that they all kind of clump together under certain similar subject areas. And I'll just end with saying, our third aim was to figure out how to integrate, another checklist into practice. An ICU is extremely multidisciplinary, and truly with a focus of resuscitation, but with patients who happen to be there with longer admission and different priorities. And so we're thinking in our next steps how to implement something like this as a potential checklist. And so we're just in the beginning of an implementation quality improvement study where we're measuring and comparing clinician reported and patient and family recognized process of care using sort of sister sets of questionnaires. And we're also going to be asking implementation questions like who should be accountable for conducting a checklist like this, and when should it be conducted? And then following that step, hoping to lead an acceptability multi-method or a mixed method evaluation, just understanding the acceptability from the perspective of clinicians, because this is a new complex sort of addition to their usual work. And I think it'd be important to understand from their perspective how to integrate it into their current workflow. And so I believe that's all I have. But if anybody has any questions at the end, I'd be happy to answer it. It's a really, really high level overview of many years of work. So thank you very much for the opportunity to share that.
Thanks so much, Laura. That really was a wonderful high-level view of what was clearly, an enormous undertaking, and we all really appreciate your efforts in strengthening the science on how we can improve quality together. Far too often, I think we are not purposeful enough about engaging the patient and family's voice and understanding goals and values. So this represents huge strides forward. So that sets the stage for our next speaker, which is Professor Elaine Frijon, who is an MD PhD trained in pulmonology and intensive care medicine. She is the head of physiology department of the APHP, which is the Assistance Publique Hospital de Paris, Raymond Poincaré Teaching Hospital in Garches, France. She is also a medicine professor at the Versailles Saint-Quentin and Avena University, Paris-Saclay University, also in Versailles, France. She's a member of the Paris National Reference Center for Neuromuscular Disorders. Her clinical and research work is mainly focused on the evaluation and the management of neuromuscular and neurological chronic respiratory failure. Her PhD work highlighted the management of speech and swallowing in neuromuscular tracheostomized and ventilated patients. So Elaine will talk to us about best practice guidelines for the role and management of tracheostomy in the care of ventilator-dependent patients with slowly progressive neuromuscular disease. I am terribly sorry, Elaine, for all of the mispronunciations of your distinguished and honorable institutions, and we are very excited to hear your segment.
Well, thank you, Michael, and you did really well. I'm sorry to have given you such a challenge with all our names. Thank you, Amy and Michael, for your invitation and the opportunity to present those guidelines, which have been created over 2 years of work from a multidisciplinary team, and which is focused on specifically the management of tracheostomy for ventilator-dependent patients with progressive neuromuscular disorders. Why progressive? Because the ALS patients were excluded as the participants felt that the issues regarding ventilation were different than for the other neuromuscular disorder patients. Why those patients? Because they are the main patients concerned by tracheostomy ventilation. And just a few words to introduce on the next slide how this process went on. So this is the official text, which I'll show you is freely available to anyone who's interested. And this is issued by the Haute Autorité de Santé, which is a national institution which supervises health recommendations and good practice of care in France. So I just summarize the process by which we came to those recommendations on this slide. And the HAS has, for one of its roles, the duty to answer different questions which may be asked by a scientific society or by official institutions or by patients' association. And these guidelines came to be created after the AFM Téléthon Association asked the question to the HAS. The AFM is a very big patient association in France, which care for neuromuscular disorders, and is a huge support for research, both on treatment and management of these patients. So they went to the HAS and said, we need practice guidelines for tracheostomy in neuromuscular patients, about who is concerned by this treatment, how should it be managed, and what are the best practice guidelines. So then the HAS studies the question and deems it interesting or not. In this case, they did. And what they do is that they gather an expert group, which is a multidisciplinary group with experts on different type of specialties who are going to work together for several months and do a very extensive literature review and are going to give their expert opinions on the best way to manage the question that they've been asked. So you'll see on the next slide the working group which was gathered on the left, and there were many different medical specialties with neurologists, pediatricians, pulmonologists, intensive care doctors, but also, of course, nurses, physiotherapists, and speech therapists, and patients also participated in this first work. So this is like an 18-month work going through the different literature, evidence-based data to see what are the best practices for the management of these patients and gathering together the expert opinions of the different participants. Once they do that, they write a first guidelines and then they send it to a reviewer group you see on the right, and they ask to all those people to read the first guidelines and see if they agree with what was proposed by the first group and to make new suggestions. And this is sent back to the working group who is going to finalize the guidelines according to the opinions and reflections of the different participants. And this is how we came to have those practical guidelines about the management and the multidisciplinary management of neuromuscular patients requiring ventilation through a tracheostomy. So after 2 years of work, we started in 2019 and finished in 2021. You'll see on the next slide the results of those guidelines, which are fully available on the links I've provided. And as is usual for the HAS, they provide two documents. The first one are just the guidelines with key points and a very detailed description of what should be the appropriate management for the patients. And then you have the second text, which is a summary of the analysis of the literature, and you have the extensive bibliography which was used to support some or parts of the recommendation. So once that is said, this is like a 56-page document as far as the guidelines, but the authors highlighted a few key points, which I'm going to detail on the next slides to show you which were the points deemed very important for the multidisciplinary group who handled the question of tracheostomy in ventilator-dependent patients. So the first, I would say the first and foremost question was, is there still an indication of tracheostomy in neuromuscular patients presenting restrictive respiratory failure? And this is an important question because we know the practices varies across the world. And we know one of the reasons that they vary are also the healthcare system, which can allow the conducting ventilation at home with a tracheostomy. And this is something which fortunately we're able to do in France because of our healthcare system, but we know that in other countries, this might be a limiting factor for choosing this technique. One of the most important points for every expert was that tracheostomy still has a potential indication in ventilation, but it's always on the after trying all our best to do non-invasive ventilation associated with cough assistant techniques in order to try to manage non-invasively respiratory failure. So this was a very important point of the guidelines, was that first and foremost, the teams managing those patients should try to optimize non-invasive ventilation, help with the cough assistance techniques in order to only go to tracheostomy when there were a failure of non-invasive ventilation, and there are definitions about what they considered as failure of non-invasive ventilation. The other point, which was highlighted by Laura, is to include, of course, the patient in the process of decision, and that this requires absolutely the consent, the informed consent of the patients, and their, in French we call that person of trust, personne de confiance, who is a person to whom you may ask what the patient's will is when the patient is unable to express himself. And this was the second highlight, which was very important for all the participants. Then we move to the recommendation regarding the procedure of the tracheostomy. We worked with surgeons, ear and throat doctors, and intensivists, and everybody concluded that the best way to practice to perform tracheostomy was as often as possible to do it in a non-emergency environment in order to be able to prepare the best surgical environment to the patients and to be able to provide the best choice. And one of the conclusions of the expert was that this should be done in, of course, an hospital environment, and that the surgical performance of the tracheostomy was preferred because this is going to be a technique which is going to be used over several years, and to all the experts, it seemed that surgical approach of the tracheostomy was much better than percutaneous tracheostomy, which are sometimes used in ICU, not sometimes, often used in ICU settings. And last, there were recommendations about the care right after the procedure and the surveillance that the patient should have in this situation. And in France, we insist that the patient should be closely monitored until the first tube change, because until then it might be an unstable situation and the patient should be in a appropriately surveilled environment. Then we moved to the care that should be done after the procedure per se, on the next slide. Which is once we've gone out of this acute management of the tracheostomy procedure and the first tube change, was to, in the best of cases, try to have the patient in a high dependency unit, which would be as the type of unit Laura described, where she's practicing, where the patient should be able to have multidisciplinary management in order to undergo rehabilitation for managing swallowing and try to improve speech in those patients which most of the time are completely dependent on ventilations. And the recommendation describes the different type of approach which can be considered to try to improve and optimize speech for the patients, while adaptation of ventilation can help in these cases, and also how swallowing should be monitored during the first weeks of the tracheostomy placement in order to ensure that the swallowing quality, of swallowing of the patient is appropriate to return to per os alimentation. Last, not last, before last, they reminded also that it was important not to forget to associate treatments which are important in those patients who not only have respiratory failure, but also have difficulties for the management of secretion, and not to forget to reintroduce or introduce the techniques which might help for secretion clearance, and not to forget to use techniques such as cough assist or IPPB to help the patient to manage the secretion, which is quite important, even if we have now the tracheostomy, which helps in the suctioning, but does not resolve all the problem of secretion accumulation in those patients. At last, the experts insisted on the importance of training the patients and his care or her carers to help them face potential emergency situation once they go back at home, and that all the important emergency situation should be covered before the patient is discharged, and that the helpers and carers should learn how to manage a tracheostomy, especially in those patients who have most often severe motor function impairment and cannot be autonomous on the tracheostomy management. The last key points, which was, sorry, just before, can we go back to was about tracheostomy tube. I just wanted to say something because it might seem strange for some people or some countries that they insist on that, but we had a problem, not a problem, but in France, we had a problem a few years ago because with the regulations, we considered that any invasive, any device which stays in the body is invasive if it stays more than 28 days. And therefore, the manufacturers have much higher regulation requirements once they have a completely invasive device that they provide. And so the tracheostomy manufacturer decided that they recommended the use of tracheostomy tube for only 28 days, because then they're only considered semi-invasive, and therefore do not have to respond to the legal requirements. And this was a big question because we knew some of the patients use the tracheostomy tubes for more than 28 days for some of them, but this is a legal environment we have. This is why we have to comply to the legal system and use a tracheostomy use for no more than 28 days. So this sums up the main key points, but of course, I told you this is like a almost 60-page recommendation, so there are much detail and which are provided in the complete text. And this is free and completely accessible. So the HAS translated the guidelines so that they could be used by all the multidisciplinary teams who are managing tracheostomy patients, and that they could be useful in those different environments. And this highlights also the fact that we felt that many we could give recommendations for patients who were managed outside of the reference network for neuromuscular disorder patients, because we have an organization with different referral centers, but sometimes the patients in the acute situations are not managed within those centers. Last, I added this additional resource, which is for the French readers, but just if some of you are interested, this is a database which was constructed by a colleague, a pharmacy colleague, because the medical devices in France are managed by pharmacists, as we define them, and she reviewed all the tracheostomy tubes available in France and measured all them and constructed this database to help in the choice of device. So even though it is in French, it's pretty straightforward. I show you the interface, and you can put in the different requirements you have for your patient, and the database gives you suggestion of tracheostomy tubes you can propose for your patients. It might not review all the tracheostomy tubes you have in your country, because she only surveyed the tracheostomy tubes which are available in France, but this might help you in your choice. And this is also a free access database, which was sponsored by the Fondation Garches, which is a non-profit foundation which supports research and work for patients with a neurological disability. And thank you very much for your attention.
Thanks so much, Professor Prigent. We really appreciate all of the pioneering work that you and your work group and team have done to make this information freely available to the public and community. As we were preparing for this webinar, it really made me think of some of the history of our organization and the Global Tracheostomy Collaborative, including some of our keynotes who've been individuals that have struggled with progressive neuromuscular disorders, from Stephen Hawking to O.J. Brigance, and others to the patients that we see each day. So this, this sort of guidance is improving the standard of care available. And I know that at our own center, which is a center of excellence for care for patients with ALS, this guidance is going to be extremely helpful. So our next speaker is Dr. George Toumanopoulos. He is a consultant physiotherapist in intensive care at St. Vincent's Hospital in Sydney, Australia. George has extensive international clinical, teaching, and research expertise in critical care, spanning work in Australia, the United Kingdom, and the United States. George has over 80 research publications in peer-reviewed journals. He initiated bespoke training courses in lung diaphragm ultrasound for respiratory physiotherapists. His main areas of research include the investigation of novel outcome measures to assess retained secretions and use of lung ultrasound for clinical decision-making. He also investigates physiotherapy effectiveness in intensive care, including recently exploring the role of laryngeal ultrasound to guide delivery of non-invasive ventilation. So George is going to speak to us about specialized bundles, teams, protocols to deliver acute respiratory and rehabilitation care. We're delighted to have you, George.
Thank you, Michael. And thank you very much to the two previous presenters. Am I on, Michael? Yeah. There we go.
Yes, we can hear you.
Yeah, great. So good morning from Sydney, Australia. So we know that a tracheostomy may confer benefits over prolonged endotracheal intubation as a means to improve airway stability, facilitate oral intake, communication, rehab, increase patient comfort, and obviously to facilitate weaning from mechanical ventilation. However, we're also aware that having a tracheostomy and the requirement for ongoing ventilation may be associated with high morbidity, longer-term mortality, increased costs of care, often due to longer hospital stays, and the requirements to maybe be discharged in long-term care facilities. To that end, how we deliver care should impact patient outcomes. A recent systematic review published by Musser and others in 2021 developed clinical practice guidelines to evaluate the impact of tracheostomy bundles, tracheostomy teams, and protocol-directed care on key patient outcomes. These three recommendations were made. Tracheostomy bundles decrease time to decannulation, trachea-related adverse events, and improve tolerance of oral diet. In addition, multidisciplinary trachea teams decrease the time to decannulation, length of stay, trachea-related adverse events, and led to increased use of speaking valves. There is also evidence that supports the use of weaning and decannulation protocols to guide weaning and the removal of tracheostomies to improve time to decannulation. Now, to better understand whether our patients are ready for tracheostomy decannulation, whether the patients can effectively clear airway secretions, both spontaneously or with airway suctioning, we need to go back to the basics of cough. This figure from a recent publication by Chatwin and Wakeman in 2023 highlights the important components of normal cough. The blue lines represent gastric pressure, red is esophageal pressure, and black is the transdiaphragmatic pressure. And these are superimposed on the grey line, which is the flow changes seen during a cough. So I'd like you to focus on the grey line. The first arrow, arrow 1, indicates the start of a deep inspiration. The second arrow is the forced expiration against closed vocal folds. The third arrow is the sudden opening of the vocal folds. And the fourth arrow is the compression of the chest wall or the intrathoracic airways with the expulsive cough. Now, for anyone over the age of 12, a peak cough flow that exceeds 360 litres per minute is considered normal. However, with the presence of a tracheostomy tube, that prevents this second phase of cough or the closure of the vocal folds. Now, airway suctioning will be effective if the cough response is adequate. And by that, with a tracheostomy tube in place, we mean a peak cough flow or a peak flow greater than 60 litres per minute. Whereas if the individual was non-intubated, you need a cough flow of at least 160 litres per minute. If not, then additional techniques, as mentioned by Eileen, will be required to facilitate a peak cough flow. And we had a recent review paper by Tronstad and others that would include techniques such as manual assist cough, chest wall compression or vibrations, manual lung hyperinflation, or mechanical insufflation, exsufflation. Now, if the cough flows are measured through the mouth, for example, with an vocal cord closure, then we can call it true cough peak flow. Whereas if it's measured through a tracheostomy tube or an ET tube, it is more peak expiratory flow because we are bypassing the vocal folds. Now, an insufficient cough strength has a key role in extubation and decannulation outcomes, especially in patients with neuromuscular disorders or RCA-acquired weakness. Now, cough strength measured by evaluating peak flow during coughing varies depending on whether the flows are measured through the mouth or through the tracheostomy or ET tube. And in this small study that you see now displayed by Kowalski, they evaluated peak cough flow in a small group of 20 patients with a mean age of 64 years, and they had been ventilated for at least 60 days with a tracheostomy, and with the tracheostomy cuff inflated, and they measured cough both with the trachea cuff inflated and with the trachea cuff deflated with a speaking valve in situ and with a mouthpiece. And this was done in a randomized order. And what of note, what I want you to see on the graph is that the peak cough flow was 38% greater with the cuff deflated. And this was a value of 160 litres per minute versus only 100 litres per minute with the cuff inflated. Now, if the cough flows are for patients, therefore, with acquired brain injury, they often require long periods of having a tracheostomy tube in situ for airway protection and or prolonged mechanical ventilation. It has been recognised that a fast and safe decannulation improves outcomes and facilitates recovery. Nevertheless, few studies have provided evidence for decannulation criteria, despite the high prevalence of acquired brain injury subjects with tracheostomy tubes in situ. This population is characterized by not only severe neurological impairment, but also by cognitive disorders, which alter motor control and the ability to execute simple voluntary tasks. In addition, these individuals often have a tracheostomy tube for a prolonged period of time, which increases the risk of adverse events such as the formation of granulation tissue, tracheal stenosis, or tracheomalacia. Now, the aim of this study by Enrique et al. Was to assess which clinical parameters are best predictors for the decannulation of subjects with acquired brain injury. They recruited 74 consecutive ABI subjects. First, the subjects underwent the original decannulation assessment for cannula removal, followed by the experimental decannulation protocol that you see now. The experimental decannulation protocol included a voluntary cough, a reflexive cough that was assessed with inhaled citric acid, tracheostomy tube capping, which was expected for at least 72 hours, a swallowing or instrumental swallowing assessment. There was an expectation that there was only a requirement of less than 2 suctions every 8 hours, an endoscopic assessment of airway patency, for example, the size of the trachea airway with a lumen diameter expected to be greater than 50%, saturations or oxygen saturations greater than 95%, and an appropriate level of consciousness with a Glasgow Coma Scale greater than 8. The reference standard was the clinical removal of the trachea tube within 48 hours. Now, 74 patients were included. This is the next animation. 74 patients were included, and of these, 57 were decannulated, where 3 of them required recannulation within 48 hours due to a lack of airway patency. 2 of the patients had tracheomalacia, and 1 patient had bilateral vocal fold paralysis. And of note, the patients who failed decannulation had a trachea tube in situ for longer periods, so 82 days versus 66 days with the tracheostomy tube. Now, the most sensitive and specific criteria for decannulation in this cohort of patients included tube capping, the instrumental evaluation of airway patency, the blue dye test, and an instrumental swallow test. Now, there are some very challenging and acute respiratory emergencies in patients with prolonged tracheostomies. Specifically, what I wanted to highlight with this case report is the issue related to severe mucus plugging. Here, this individual, this 64-year-old woman, was recovering from COVID-19, and they were weaning this patient with a tracheostomy mask in situ, and the trachea cuff was deflated. She unfortunately developed acute respiratory distress with oxygen requirements escalating to 100% oxygen. The inner tube was withdrawn and oxygen was applied, and a suction catheter was repeatedly passed with ease in accordance with the standard emergency management guidance. They also tried manual ventilation via the tracheostomy tube and also via the mouth, which were both ineffective due to stiff lungs. And there was more severe desaturation with the patient dipping down to 60% oxygen desaturation. Orotracheal intubation then was undertaken and was successful. They removed the tracheostomy tube, and there was a mucus plug that you can see on this image that was adherent to the tip of the tracheostomy tube, which created what's called a dynamic ball valve phenomenon with obstruction, even though there was they were able to pass the suction catheter. So what this case demonstrated was that even though they followed the emergency algorithm, this does not account for this scenario. And therefore, a bronchoscopy via the tracheostomy tube would have identified the mucus plug causing this ball valve phenomenon. Now, what I want to demonstrate with this animation is that with this case, I also want to highlight how potentially an aggressive chest physiotherapy intervention could have been effective in this rare scenario. We have the tracheostomy tube here in the animation with a mucus plug that is adherent or stuck to the tip of the tube. And this will potentially open up during positive pressure ventilation. But you will notice that we may dislodge the plug with positive pressure or with the passive passage of a suction catheter. And this will allow, obviously, the flow of gas during inhalation or inspiration. So you'll see the suction catheter here highlighted in yellow that easily goes past the plug. And therefore, this may make the clinician think that the tube is actually patent and open and not being occluded by a plug. However, with exhalation or breathing out, the plug then occludes the airway and prevents exhalation. And the suction catheter in this situation does not dislodge the plug. So on the ventilator, for example, the flow waveforms would show an absence of flow and there would be no tidal volumes being breathed out. And the patient, if they're awake, they would be in respiratory distress and they would be unable to breathe out. So the cough could look effective, but it isn't effective. Now, from a physiotherapist perspective, you may have a clinician jumping on the patient's chest wall, trying to provide manual assist cough, but this is maybe not going to be effective to dislodge the plug in this situation because the plug occludes expiratory flow. And this may lead to further increases in for example, intrathoracic pressure. But when we now apply suction with a second person, so if there's somebody at the head end with a suction catheter, increasing the airway or the negative pressure generated during suctioning, then if we can have a second person providing suction, trying to aspirate this sputum plug, whilst a second clinician is compressing the chest wall or providing techniques like manual hyperinflation or cough assist, then we may be able to dislodge the plug with vigorous suctioning, in addition to the use of either sterile lubricant and or very, very liberal use of sterile saline to attempt to dislodge the plug. So you'll see here in this animation now, the next animation, Amy, if we go to the next slide, you'll see now the suction catheter will withdraw the plug similar to the forceps at the end of a bronchoscope. And therefore, the techniques of manual hyperinflation, mechanical cough assist, manual hyperinflation should be effective. But it is very important that you are closely monitoring the patient's blood pressure, heart rate, and saturations whilst you're doing these techniques to ensure that we are being effective. So now we move from the management of airway secretions to the management of respiratory muscle weakness, because we know that there is evidence to demonstrate that diaphragm muscle atrophy does occur, and it occurs rapidly during even acute mechanical ventilation. It's detectable, for example, even after 18 to 69 hours of controlled mechanical ventilation. So importantly, also in patients who've been ventilated only greater than 24 hours, diaphragm dysfunction is associated with difficult and prolonged weaning, and it may be associated also with 1-year mortality. So even when we wean patients to spontaneous modes of mechanical ventilation, such as CPAP and pressure support, 1/3 of those patients may have diaphragm dysfunction, and this will impact on recovery from weaning from ventilation. Now, a systematic review with greater than 1,000 patients in the paper published by Bissett, which is shown in this slide, it demonstrated that inspiratory muscle training can improve inspiratory muscle strength and facilitate weaning from ventilation, and is associated also with improvements in quality of life. But importantly, patient selection is important, and we've got a table on this slide to demonstrate the selection criteria. But what's also important to note is that having an artificial airway such as an endotracheal tube or tracheostomy tube does not preclude the commencement of inspiratory muscle training. For further details, I'll refer you to the paper by Bissett and others. Now, acute rehabilitation across the spectrum of both acute and chronic care is important to minimize the loss of general or peripheral muscle strength, and to prevent functional decline, and to prevent the development of ICU-acquired weakness. The type of airway, for example, whether they have an ET tube or a tracheostomy tube, may impact on when and the type of rehabilitation that is deliverable. Now, in this single site ICU study by Annalisa Sutt and others here in Australia, this was undertaken across 4 years, and the aim was to determine whether the timing of tracheostomy had an impact on the length of stay, morbidity, mortality, and patient-centric outcomes towards their functional recovery. Now, after the tracheostomy tubes were placed, the patients were able to, on average, verbally communicate 7.5 days earlier, return to oral intake 7 days earlier, perform out of bed over 6 days earlier than those individuals who did not have a tracheostomy tube. And the patients with an ET tube in situ, so not with the tracheostomy tube, none of these patients obviously were able to talk or have oral intake. The majority of the individuals did not participate in any out-of-bed exercises or active rehab, and there were no clear differences, however, in ICU or long-term mortality associated with when the tracheostomy was actually done. Now, even though from the basis of Annalisa's work, we are able to show how having a tracheostomy placed will facilitate communication, will be associated with better patient comfort, oral feeding, and earlier active rehabilitation. There is also evidence as part of the RECOVER trial, which was a prospective multi-center 9 ICU study that indicated in a group of near 400 patients that were ventilated for at least a week, and these individuals were greater than 42 years of age. Of these individuals, 193 of them, nearly half, who required tracheostomies, they unfortunately had longer ICU stays, longer hospital stays, and had a higher hospital mortality compared to the patients who did not receive a tracheostomy. Over a 1-year follow-up, there was also increased ICU readmissions that were more common in the patients who had a tracheostomy, and the tracheostomized patients were also less likely to be discharged home. Now, this is not a cause and effect due to tracheostomy placement, but rather it is more of an indicator that the need for a tracheostomy after prolonged mechanical ventilation is more of a marker of a more complex patient course during and following the individual's critical illness. Thank you.
Thanks for a terrific talk, George. A lot of ground covered there, and really quite illuminating as far as best practices for both decannulation as well as many aspects of multidisciplinary care and bundles and rehabilitation. So I think at this point, we transition to questions and answers. I have several of my own, but we also have some terrific ones from the audience. Maybe I'll pitch the first one and then hand it over to Amy, our esteemed host. But before I do that, I just want to call your attention to what's now on the screen, the save the date for our International Tracheostomy Symposium in 2023. So it'll be October 20th to 21st. That's a Friday and Saturday. It'll be at Johns Hopkins Medicine in Baltimore, Maryland. Our theme is building the future of tracheostomy care, and we'd love to have any and all of you join. So the first question comes from Yao Chan. They ask Professor Prejean, are topics such as ventilator-assisted leak speech, use of clearance techniques taught to all intensive care doctors and nurses in France? In Singapore, we have a great divergence between standard ICU care and ideal chronic ventilatory care. And I can certainly attest that in the States as well, we have quite a gulf between the world as it should be, the ideal, and what happens on the ground day to day. So if you could apprise us of the present state in France, as well as what you understand what's happening in other parts of the world.
Well, I would say it's the same way. There's except for some ICU unit who are more sensitive to the topic, and it's not something that most of ICU doctors know how to do. And I think one of the reasons is because you cannot do leak ventilation with an ICU ventilator. You need to use a long-term ventilator, home ventilator, to do that, because then you can control the alarms and you can ventilate with an uncuffed or deflated cuff tracheostomy. So it's the gap exists also in France. We try to communicate about it. We have several formation, and they invite me to speak about it, but it's a little bit it needs a lot of work to convince intensive care doctors that they can do that. And we try to give the good speech to everybody, but one of the main thing is that is being able to send the message that they need to change the ventilator in order to do it. And this takes quite sometimes to be able to make them do that.
Thanks so much for that perspective. I've certainly enjoyed reading, your works. Congratulations on not only the guidelines, but also the recent comment in Lancet Respiratory Medicine that provided a nice introduction and overview for those looking to advance the practice in this area. Well, why don't I hand it over to Dr. Freeman Sanderson and let her present a few questions to our panelists.
Thanks, Michael. In terms of questions for the panel, in terms of in all of the work that you've presented, are there any caregiver training materials that you also distribute or share with families and community for people with tracheostomy? So maybe sort of taking that forward, Laura or Elaine, do you want to comment on that? So resources for the families.
We don't have a standardized pamphlet. I think that would be very helpful, but we don't. So it's very much what the teams, isolated teams, what might do for patients. We're trying in our institution to formalize a training for caregivers, not only with material, but also using simulation mannequin. I'm not sure, sorry about the, if that's how you describe them, but we're working on programs to train both hospital caregivers, nurses and nursing help, but also to train the families. But we don't have any pamphlets formally done. For that, we have some material which is provided by the IFM, which I talked about, which is a very big patient association in France, but not any official material on the subject. I don't know about you, Laura.
Thanks.
We have some. We have a few things. We do have some resources on our hospital webpage for patients and families with regards to tracheostomy management. We also have we have a collaboration across Ontario. So in our province, it's the Ontario Provincial Long-Term Ventilation Strategy. And what they're working really hard to do, we're part of the sort of central region for it. What we're working hard to do is to align practices across Ontario with regards to that prolonged and long-term ventilation, including tracheostomy management. And one of the initiatives that they sort of started out with in the first few years of this collaboration was to create an online portal that has like videos that are intended for all audiences, whether it's clinicians or like multi-professional clinicians, patients, and family members. And there's some additional contributions we're starting to add to it. And one of them is a little bit like the talk I gave today, just an overview of, what it means to have a prolonged ICU admission, what you can expect in your care in terms of, risks and care practices. And so that's one additional contribution. My colleague, Dr. Fraser, is adding a module on weaning. And so we're trying to orient it, just as you suggested, Amy, towards patient and family comprehension as well. So that they're kind of walking along with us as we learn and manage their complex care.
And, very much so, it's across all three talks have highlighted the importance of the involvement of, every stakeholder, that there are multiple stakeholders, both sort of in the immediate care, but really sort of coming up and looking at the longer term care and the functional requirements, as you mentioned as well, in all of your talks. I've got one question, if that's okay for George, just particularly in regards to suctioning and airway clearance, just in terms of people that have a long-term tracheostomy with persistent and critical illness, about I guess sort of reducing sort of trauma. So how do we balance that sort of clearance and airway trauma?
It's a good question, Amy. I know maybe some of our North American colleagues may be very familiar with this, but some people advocate atraumatic suctioning. So, for example, passing the suction catheter down to potentially just clear the endotracheal tube if you're orally intubated, or the tracheostomy tube, so not to go beyond the tip of the tube and not to hit the carina. So there's trying to reduce the risk of traumatizing the carina with repeated suctioning episodes. There's very limited evidence to support that kind of practice. I know the American Association of Respiratory Care often may advocate this as being kind of like an atraumatic form of suctioning. But my concerns with that is that you may be similar to the case study that are reported. It'd be very difficult to then exclude that you have a mucus plug or some kind of like encrustations of mucus forming around the end of the airway, the end of the tracheostomy tube, for example, without advancing the catheter beyond the tip of the tube. But also, I think that especially in our neuromuscular disease cohort, I think you need to stimulate a cough to then be able to establish whether the individual has got sufficient strength to generate a sufficient expiratory flow to clear secretions either out of the tracheostomy tube, so you may be able to get away with a less traumatic suction. But then you won't know whether that individual needs those additional techniques that Elaine mentioned, such as mechanical insufflation, exsufflation, manual hyperinflation, or manual techniques. I think there's a bit of a trade-off. I would always advocate that you need to trigger a cough to see how effective that person's cough response is. Then you may be able to establish the type of suctioning that's required. Does that kind of answer the question?
Yeah, and I think it's coming back to having your team members and evaluating each person, and each situation as an individual, and looking at sort of what's best and considering, the different aspects for what that individual needs. Okay, I want to hand over to Dr. Brenner, just in terms of any other questions you have as well.
Sure. Well, this one kind of dovetails on what we were just talking about in terms of suctioning technique, and also some of the questions around decannulation. So I was just curious about what is on the horizon, new approaches that are emerging in terms of this population of patients. Some of the things that come to mind for me are there was a New England Journal of Medicine article about a year back or so where they talked about high flow oxygen and suctioning as tools for, as a algorithm and protocol for decannulation, but they excluded individuals with neuromuscular disorders. So we don't really know whether that sort of protocol would be useful. There's been some work with diaphragmatic pacing. And then there are also, innovations in areas like making the devices more intelligent, potentially adding capnography or other technology, which as you were talking about that really compelling example where there was a mucus plug at the end of a tube. I thought of other instances where I've seen similar things. I've seen it with granulation. I've had a case where there was a herniated cuff that actually dynamically ball valved as well. So there are all sorts of ways in which things can go bump, in addition to the usual false tracks and bleeding and otherwise. So I was just wondering, for this population that lives with a long time with tracheostomy and needs to safely navigate those challenges, what do you see on the horizon, both for routine maintenance care as well as potential strategies for decannulation for those who have tracheostomy? Big question, sorry.
Well, to address some of the techniques you've mentioned for the diaphragmatic pacing, there was an experiment in France with ALS patients, as I'm sure you know, to try to evaluate whether preventive pacing would help to preserve diaphragmatic function and to delay the recourse to ventilation and the morbidity. And as you know, it was stopped before the end because there was a higher morbidity and mortality in the group which received the pacing. And as for France, we're not exploring right now the use of diaphragmatic pacing outside of the clear lack of central stimulations. So for Ondine patients or for high tetraplegia patients, but we're not exploring as of now it as a technique for muscle training, for example. Sorry, I took a long time, so I forgot the other techniques you mentioned. For the high flow cannula, there's been a very the high oxygen flow. I don't know if there's a space for that. Of course, for my area, which is our neuromuscular patients, that's kind of the problem, because oftentimes the neurological or the neuromuscular patients are excluded from the big studies, so we don't know what would be the interest. I'm a little bit doubtful because I think in the case of chronic restrictive respiratory failure, the mechanisms is the failure of the respiratory pump, and I don't see the high flow as something supporting the muscles, so I'm not sure that would be an appropriate way to wean patient. But of course we need to evaluate, but I'm not very confident in the help it could provide. And as for decannulation or ventilation, I think the progress which has been made over the past few years is the ability to go back to non-invasive ventilation even for dependent patients. And as for decannulation, what we do for patients, we still require ventilation, but have some sort of autonomy, respiratory autonomy. We try to ventilate them before taking out the cannula. So we have, which is not very evidence-based, but period where we ventilate the patient still with the cannula in place, and then before we, to ensure that we have an appropriate efficiency of the ventilation before taking the cannula out. But it's more experience-based than evidence-based. I don't know. Sorry.
I'm sorry. Thank you for such a thoughtful response. And that really does help us illuminate what the current state is. I know that anecdotally, sometimes a combination of CPAP or high flow oxygen have been used, maybe in combination with the cough assist, is to tide people by through certain procedures who may not yet require non-invasive ventilation, but still struggle. So it's interesting to see how these, other approaches are, are implemented into the algorithm, but probably the gold standard, it sounds like, remains the preferred approach. Other input from you, Laura or George?
Michael, I was going to add, you mentioned, I think, about secretion clearance. I think they're now developing, I've seen the development of tubes which can be coordinated with the ventilators. So you can either have a mixture of the options I've seen, cough deflation during exhalation, and you get secretion clearance during the exhalation phase to try to minimize the use of invasive suctioning. In addition to that, I think like subglottic ports for suction, I think they've also developed ports at the tip of the tracheostomy tubes, again, which can be coordinated with the exhalation phase of ventilation to suction the tubes more during each phase of exhalation. So therefore, again, the individuals may in the future not need as frequent invasive suctioning. That's what I've seen being published, which would be great to try to minimize some of the risks we are talking about.
Terrific. Thanks so much, George. Amy, closing remarks?
Yeah, I just sort of acknowledging some to the audience, the additional questions that are in the chat. I'll make sure that we do have a copy of those, and all of the your questions are answered as well, because I'm mindful that we've gone over the time. But just in terms of last messages, we mark your calendars for our next GTC webinar. So at the moment, that's penciled in on the 3rd of August, 5 p.m. Eastern Standard Time in the US. But please visit the GTC website there below. All of the talks are recorded and they've been placed up on our YouTube channel. So they're all freely accessible. So please make use of that, the great resources there of education. So thank you finally to all the panelists for your time, not only today, but in preparation for this talk, and to all the audience members who also joined today's session, and for those people who are listening to the recording. We really do value your input into the tracheostomy community to really improve and enhance care and outcomes. So with that, good night or an early good morning if you're in Europe. It's just ticked over midnight, and good morning if you're in the Southern Hemisphere. So have a great day, and we'll see you all next time.
Thank you very much. Goodbye.
Thank you. Bye-bye.